Hello, Jai Jinendra Pranam, and good evening to everyone. Welcome to our Oshwal Wellbeing and Lifestyle webinar on this really cold November evening. We're going to be talking today about skin disorders and their treatments. But before that, we would like to take the Navkar Mantra prayer with Jayesh Bhai.
Om Namo Arihantanam. Om Namo Siddhanam. Om Namo Ayariyanam. Om Namo Uvajjayanam. Om Namo Lo Esabvasahunam. Eso Panchanamukaro. Sabbapavapanasano. Mangalanam cha Savveshim. Padhamam Havai Mangalam. Arhanto Bhagavanta Indra Mahita. Siddhascha Siddhi Sthita. Acharya Jina Shasano Natikara. Pujya Upadhyayaka. त्रिसिद्धान्तसुपाठिका मुनिवरा रत्नत्रयाराधिका पञ्चैते परमेष्टिनः प्रतिदिनं कुर्वन्तु वो मङ्गलम् कुर्वन्तु वो मङ्गलम्। ઓશવાલ એસોસિએશન ઓફ ધ યુકે તરફથી આપ સૌને પ્રણામ। આપ સર્વનું આરોગ્ય સુખાકારી સારી રહે અને ખૂબ સારા કાર્ય કરવાની શક્તિ દેવ ગુરુ અને ધર્મ પસાએ પ્રાપ્ત થાય એ જ પરમાત્માના ચરણમાં વંદના અને પ્રાર્થના।
Thank you very much, Jayesh Bhai, for the Navkar Mantra prayer. And welcome everybody to today's session where we are going to be talking about all things skin and skin conditions. Today we are joined by two eminent professionals, Dr. Namita Jasani, who is a consultant dermatologist and works for Whipps Cross and Bart's NHS Foundation Trust. Namita has developed expertise in a wide range of skin conditions ranging from general conditions, pediatric and skin cancers. Fully registered with General Medical Council since 2005 and has done training at some of London's most prestigious hospitals, including Barts, the Royal Free, the Homerton and City Hospitals. We thank you very much for giving us your time today. We're also joined by Dr. Pamela Kaushal from the Oxford NHS Foundation Trust. Pamela is a consultant psychiatrist, and today we will also be talking about some of the mental health that is related to skin conditions, and Pamela will be giving us top tips to help us manage some skin disorders. We also have with us Anthony Fernandez, who is going to be talking to us and sharing his experience of living with psoriasis on his hands. But before we do all of that, I'd like to introduce Tushar Bhai from Oshwal Association of the UK. He's Vice Chair of OA UK and here with us every webinar. Tushar Bhai, welcome.
Thank you, Profula Ben. And I welcome everybody to this November's winter evening. I hope you're all wrapped up well. So pleased to welcome you all today to another fantastic webinar. Our topic, as Profula Ben explained, is skin orders. All of us, in our lifetime will be affected by skin disorders once in a while, whether it's a fungal infection, dry skin, eczema, dermatitis, etc., etc. So today we're going to hear from two very well experienced consultants in their own fields, different topics, but both related to skin. And obviously we have a case study. So without taking any more further time, over to you, Profula Ben.
Thank you, Tushar Bhai. So first of our speakers today is Anthony Fernandez. Anthony, thank you so much for joining us and for giving us your time this evening, and for sharing with us what is going to be really probably quite helpful for a lot of people with the same condition as you. And you're going to talk about living with psoriasis on your hands. So when you're ready, please start. Thank you.
Hello, my name's Anthony Fernandez. I've been living with psoriasis for, well, to be honest, most of my life, most of my working life. I've been working for over 40 years. If I can just show you, it's always on the back of my hands. I've tried all sorts of treatment for it, been to hospitals where they put all sorts of lights on it, light treatments, all sorts of different creams. But to be honest, I think it's something to do with it's work related. I work as a chartered quantity surveyor. So it is a stressful sort of job where you've got to look at figures, especially towards the end of the month, to try and make sure that you've got enough for your overheads and whatever. So it does get a bit stressful, and I've noticed that when I go on holiday, it kind of disappears completely. And then as soon as I go back to work, it's back again. As I said, I've tried all sorts of home remedies. You name it, I've tried it, but it just will not go. I suppose the only time it'll go is when I retire. That's about it. Obviously, it does get embarrassing when I meet people and I go and shake their hands. They kind of look at your hands and say, "Oh, what's wrong with your hands?" sort of thing. Especially people that don't really know what it is. But it's something that I've got to grow with and live with and just carry on. So if anyone's got any sort of suggestions as to how I can get rid of it, please tell me. I'd love to know. That's about it.
Thank you, Anthony. And it was interesting you saying that it flares up certain times of the month. So you recognize that it may be to do with the stress of your work.
I'm totally convinced that it is to do with work. Because as I said, if I go on holiday or I'm away from work, it tends to go a lot less. Or if I'm away like for a 2 weeks holiday, go to Canada to see my sister, it will totally disappear. But I don't think it's related to different countries. But because I go on holiday down here, even if I go to Bournemouth, it just disappears. When I'm relaxed, I don't have any stress, don't have the usual 200 phone calls a day. It's less stressful. It goes. So.
Yeah, and I'm sure our next speaker will touch on stress and the management of some of that. But thank you for coming on here and sharing that with us. I was touched by what you said about when somebody shakes your hand, there's that kind of second of hesitation. And we'll talk a bit about how you manage that, when we take the Q&A. But brilliant, thank you for sharing and showing us your hand as well.
How bad it is.
Yeah.
No, that's because it's towards the end of the month, and the work-wise I've got a hell of a lot. So yeah, it does flare up. Because I think what I tend to do is that I itch it, and that's what just makes it flare up even more.
Yeah.
And
I'm sure.
I've tried all sorts of creams. Someone told me to put the creams at night and put white gloves on, which I've done. Obviously, your hands get all hot and sweaty and stuff like that. But just by the time I washed it off in the morning, got back to my desk, within half a day, it's back again. It's back to normal.
Yeah, so when we talk to our next speaker, perhaps there'll be some suggestions for you, particularly in terms of managing that. But let's see. And I want to thank you for agreeing to share your story and come on here today.
That's all right.
So thank you very much for that. I'm going to introduce our next speaker now, who is Dr. Namita Jasani, a trained consultant dermatologist since 2013, and is going to talk about skin conditions, the most common skin conditions, their treatment and impacts. And Namita has worked with many NHS trusts and also some private consultations as well. She's going to share with us today some information, some tips, and some treatments. So when you're ready, Namita.
Hello, good evening, everyone. I'm consultant dermatologist, and I'm going to talk about 3 common skin conditions. One is eczema, psoriasis, and acne. Starting with eczema or atopic dermatitis. What is eczema? Eczema is an inflammatory condition of the skin where you get red, dry patches on the skin. It is a chronic condition, so you'll have flare-ups that will settle down to reoccur on and off. A lot of people use eczema and dermatitis as interchangeably, but they are same condition, which means inflammation of the skin. Most common find of eczema is atopic eczema or atopic dermatitis seen in childhood. Why do we get eczema? It's because of defective barrier in the skin. I'm going to go through that in detail in my next couple of slides. So what age does it start? So eczema can start from a very young age at birth. Child may present with a cradle cap or very dry, scaly looking patches on the scalp that may resolve, and then they will see dryness on the body and red patches may develop later on. So 50% of the children can get it within their first year of life, and 85% may get it in the next 5 years of their life. A lot of children would grow out of their eczema as they grow, but some of them may carry it into adulthood. Cirrhotic eczema is a different kind of eczema, which you may see in old age, and that's because of the dry skin. I'm going to talk about this towards the end of my eczema slide. This is a slide which I want you to see, which explains a little bit what happens to the skin in eczema. So looking at the picture on the left, where the skin is normal, the cells which are there, which are triangular, they are sitting all tightly next to each other. When there is inflammation, dermatitis, the skin gets inflamed, which is red. The junction between the cell, where instead of sitting tight, the gap is increased, and this gap allows water to be lost from your skin and any bacteria or any allergen or irritation to enter your skin and cause inflammation. Which area is affected by eczema on the body? So the distribution changes with age. So a newborn or an infant can have eczema in any part of the body, most common face, scalp, and then any outer part of the arms or legs. But when the child grows into a few years, you will notice that it localizes to the creases of the body. So on the elbow crease, on the knee crease, or on the ankle area. And if the child carries the eczema into adulthood, it may get localized to hand or feet or on the trunk. I'm going to show you some pictures of how eczema can look on the skin. So this is a picture of a child, infant, who's got red, dry patches on the body. This is a picture of a child who's got red, dry patches on the ankle area, which is on the extensor surface. Again, a child who's got extensive eczema on the hands, where you can see redness, scratch mark, inflammation. Picture of a child who's got eczema on the face area, on the cheek, on the eyelid area, where you're seeing redness and dryness and flaky skin. On the back of the knee, where we are seeing redness and dryness and scratch marks. So eczema can look different in different skin color. So if we look at this child who's got darker skin tone or Asian skin tone, the skin on the abdomen is normal. The skin on the hand is affected with eczema, and you can see the skin has become thickened. There are scratch marks and it's looking pigmented. So there's more color in certain areas. This is because eczema has been chronic for a few weeks. Again, it can cause discoloration on darker skin tone, which can be of concern. As you can see, there are dark marks where the eczema has been recurrently flaring up. Sometimes young kids, when they get eczema, they may heal up by losing color instead of getting color. So we call that hypopigmentation, post-inflammatory. Just touching through the treatment of the eczema. So picture on the right is you can see is the healthy skin, where the skin cells are sitting nicely together. The barrier of the skin is intact. What happens in eczema is the barrier is broken down. The cells, there is increased gap and there's more loss of water. Any environment irritant can enter your skin because the barrier is broken. The key of treatment, we always say moisturize, moisturize, moisturize. Why is that? So if we look at this slide here, normal skin, intact barrier, bacteria, irritants can't enter your skin. When you got inflammation, you got dermatitis, the barrier is broken, can allow bacteria to get in, can allow irritants to get in, and the water is lost from your skin and the barrier is broken. And when you use a moisturizer, you're trying to restore the barrier back. So you're putting up the grease, which restores the barrier, the cell junction is sealed up, and it prevents any allergen or any irritant to enter and prevents the organism to enter. So key always stays moisturize your skin. Patient always asks, which emollient is best for me, doctor? So we say there's nothing which is best for you. Every patient will have a different emollient which would be best for them. So if we look through this chart, lotion is considered as the lightest, while the ointment is considered as the greasiest. So normally in patients with eczema, we will say you either use cream or use ointment, or tend to use ointment towards the night where the moisture content we want higher because you're not applying any cream for the next 12 hours. So anything which is lotion based will be lighter. Cream is something we will say use in daytime, and ointment is greasy. So you want to use if you got a very dry skin. Treatment of the eczema. This is a very brief slide and it's the big topic to talk about, but I'm just going to brush through the main topics of this. So as I explained in the previous slide, moisturizer is a key. We say apply it multiple times a day and liberally, and few times in day and nighttime use an ointment. Steroid creams and ointments are used. They help to decrease the inflammation, so it will take the redness down and improve your symptoms of itchiness. So if somebody has got VP, wet eczema, we say use creams. But if you got dry eczema, the skin appearing dry, then use ointment because that will give you more moisture and it has got less preservatives. Immunomodulator creams have been used for the last few years. What they do is when you apply locally to the skin, it decreases the inflammation by interfering with the inflammatory cells, and that's how they work. Some patients may have widespread patches and they may not be able to use cream constantly all over. Then we may consider them for light treatment. Again, light treatment may help you for a few months. It's not going to cure your eczema. So all this treatment will help you as long as you take the medication. The moment you stop, there's chances the eczema would reoccur. Some patients have frequent flare-up, then they may go on drugs by mouth, which could be immunosuppressant. And there are a few drugs which we could give it to the patient according to the age, suitability, and areas involved. And since few years, we have got injectable, which are given as an injection, and they are biologic like dupilumab. Again, another frequent question patients ask, I'm not sure how much steroid to use. So we say follow this fingertip unit rule, which says from the first crease of your finger to the tip of your finger, you put the cream or the ointment, and that area will cover your both the hands with fingers close to each other. So just as an example, this is an infant, and one fingertip unit is enough to cover whole of the scalp and the face area. But if it was an adult, it will require 2.5 fingertip units. So just a guideline how much you will require, how much area is involved. It's a good website which you can use. This is made by dermatologists and guys in St. Thomas's, which gives advice to the patient how to use a steroid and how to use emollient and how much to use. Prevention of the eczema. So when patients don't have a flare-up of eczema, what do we do in between to decrease the flare-up of the eczema or increase the period of remission in between? We say moisturize, even if you don't have, moisturize frequently, so you're restoring your skin barrier. Avoid using soap because they will be harsh to your skin. They'll strip off the natural oil from your skin. Avoid hard detergent for washing and everything. Some patient knows what triggers that eczema. So if extreme temperature, that can be likely triggered in eczema patients, especially in winter when the heaters are on, humidity is less in the air, and there is a lot of dryness that can be a trigger. So avoid extreme temperatures. Fragrance is a known irritant in few patients, so avoid that. So don't use fragrance soap or fragrance moisturizer. I want to run through a few myths and facts about eczema. So patients come and say, I will not bathe my child regularly. And we will say, why is that? So they say, oh, that is going to dry the skin out. So we say, you should bathe the child regularly. You should do short bath. They should be warm. And you should put some oil substitute. So you can either have a soap substitute or a bath oil. And what that will do is that will sip into the skin and hydrate the skin, so which is good for the skin. A lot of patients have a belief that eczema is from food allergy. So as a dermatologist, we will say eczema, patients have increased risk of getting food allergy because the patient has moderate to severe eczema, they get sensitized to a lot of food allergen, but every patient will not have a food allergy. So to know about the food allergy, a good history taking is important. And if required, then either a blood test or a skin prick test can be conducted to find the allergen. A lot of parents worry, I don't want to use steroid because that is going to damage the skin. So we as a dermatologist would say steroids have been used for 50 years and they are safe. If you use steroid the right amount during the flare-up to control your flare-up, it will improve your eczema, it will improve your quality of life. A lot of patients say what advice to give when they say, what sunscreen should I use? So there are two types of sunscreen. One is a chemical sunscreen and one is a physical sunscreen. So physical sunscreen will form a barrier on your skin and it will reflect the sunlight. And those physical sunscreens are good for patients with eczema because it forms a barrier and reflects. So they would have a white tint because they will either have a titanium or a zinc oxide in it. So it may not be cosmetically very acceptable to some skin color because it will leave a white tint, but it is good because it will reflect the sunlight. There are a few brands which do good sunscreen in eczema patients. Again, common question asked is, should I swim or should I not swim if I have got eczema? So we say you can swim, but make sure before you go for the swimming, you put a lot of moisturizer on your skin so it forms a good barrier and prevents the chlorine water to come in contact with your skin, because we know chlorine water is irritant and it will dry out your skin. Once you're done the swimming, make sure you rinse, take a shower, remove all chlorinated water from the skin, dry your skin and put a good layer of moisturizer back on. If you're doing outdoor swimming in summer, wear protective clothing, which has got sun protection. And if you have a severe flare-up, then you do want to avoid swimming during that time. Just to touch on xerotic or exotic eczema, which we spoke about in one of the first slides, this eczema occurs in old people and it's because of dryness of the skin. As we age, the natural greasy glands, the sebaceous gland, the sweat gland decreases in our body, and that predisposes us to dry skin. And commonly seen on the trunk area or on the lower leg area. So what do you do for that? So you should avoid using harsh soap. You should use a cream cleanser or use like Aveeno wash or anything which has got a little bit of more moisture than a normal soap. You should moisturize with a greasy cream a few times a day. And you should avoid very hot water bath because that will dry out your skin. These are some of the examples of how xerotic or ectotic eczema will look. You can see the redness here, dryness of the skin on the leg. And again, redness and dryness of the skin on the leg area. Coming through another chronic condition, which is psoriasis. So what is psoriasis? Is an inflammatory condition of the skin and is immune related, where there is overactivation of the immune system. It can affect any part of the skin and you will see red and thick scaly plaques on the body. It can affect your scalp, it can affect your nail, and sometimes it can also affect your joints and give you psoriatic arthritis. Who gets it? Anyone can get it. What is the cause for psoriasis? So in psoriasis, your immune system is overactive and it's the wrong signal, so your inflammation happens and the cell turnover is very fast. So normally a skin cell will turn over 28 days, but in psoriasis, the turnover is very rapid in a couple of weeks. And if you have a family history, you're more likely to get it. Again, it's a slide which just shows how the skin will look like under the microscope if you have psoriasis. This is a normal looking skin where there is a top layer, the middle layer, and a fat layer. But in psoriasis here, because of the inflammation, there is rapid turnover of the cell. So there is a lot of scale and there is inflammation there on the skin. These are some of the pictures which shows how psoriasis will look on your skin. So this is a patient who has got psoriasis on the knee area, where you can see the redness, thick scaly plaque on the knee area. So this is a patient who's got multiple patches of psoriasis on the body. So you can see red and scaly, dry looking patches. Patient who's got psoriasis on the scalp area, where you can see there is redness and dryness in the scalp area. Again, on the back of the scalp, where the patient has got very thick plaque and redness. So it can affect the nails. In this picture we are seeing is indentation or little pitting, which you would see in psoriasis, and here where the nail plate is separating, onycholycosis, what we call. So psoriasis can present in different ways, just affecting your skin, which is the most common, called plaque. It can affect only nail, or it can be your skin and nail. Sometimes you get small dotty psoriasis, which we call gutted psoriasis. Sometimes you get psoriasis on your palms and sole with little pussy spots, which we call pustular psoriasis. And sometimes you can have a severe flare-up, which is called erythrodermic psoriasis. So there are some triggers which we know will flare up psoriasis, which will be different in different patients. Stress is the most common reason why the psoriasis would flare up. Sometimes you have injury to the skin from, say, a cut or something, or a graze on the knee, and psoriasis can occur on that area. Some patient may get sore throat infection, and that can trigger gutted psoriasis. Smoking is also known exacerbating factor, and certain medications can. So it's good to review the medical history and the drug history as well. Treatment. So again, this is a very broad topic to cover. There are treatments which will help to treat your psoriasis, but again, they are not curative. They'll help to control your flare-up as long as you use it. So again, coming back to emollients, they are the key of all treatment for the skin. You want to restore the barrier. You want to remove the scales, so the emollient will help to soften the scale. So there are calcifitrol, which is vitamin D derivative, and what it does, it decreases the inflammation and decreases the way the cells are growing rapidly. Steroid creams are also used that will decrease inflammation and help you with the itchiness. Coal tar work as anti-inflammatory, and they also decrease the cell growth over, which is rapid. Immunomodulators, they affect the immune system locally where they are applied. So psoriasis can be widespread, and sometimes if it's widespread, patient can have light treatment, or if sometimes psoriasis is just localized to your hand and feet, then you can have localized light treatment, what we call PUA treatment to hand and feet. Again, if the psoriasis is widespread and you can't put creams, or the creams are not working, patient may go through some medication by mouth, and there are quite a few medications which are available to be chosen from. And recently, some patients who have got extensive psoriasis, they may go down the route of injectables called biologics, and there are a variety of them. So running through the final topic is acne. Why do we get acne? So it's the most common teenage condition. And the reason we get is at teenage, we get hormonal stimulation, androgen stimulation, which increases the grease-producing glands. And once the sebaceous gland enlarge, it's a good medium for the bacteria to grow. So sebum is a good feeding medium for them. So they grow, they block the pores, and this causes inflammation, and you get acne spots. If you have a family history, the chances you may get acne. This is a diagram to show what acne can look through the microscope. So this is a patient who has got sebaceous gland, which is yellow and is growing and is blocking the hair follicle, the duct area. When it's blocked, you can get white heads, or sometimes when it is open with some keratin, you can get an open comedone. Here, in the fourth picture, there is blue color, which is bacteria is growing, it's causing inflammation, and you get red and pussy looking spots. And sometimes inflammation is very intense. It may break around the area and give you a nodule or a cyst. Again, there are certain triggers which can flare your eczema. So if somebody is using heavy cosmetics, it is going to block your pores, and that can stimulate your acne. Sometimes some female patient can have polycystic ovary, which causes hormonal dysregulation that can stimulate acne. If patient is taking steroid orally for some other reason, that can stimulate acne. There's some evidence about high GI food, which essentially means high glycemic index food. So if you have too sugary food, you get spikes in your blood sugar, which allows bacteria to grow. Some of the picture how acne can look. So this patient has got black dots and some white dots. This is comedonal acne. Here, the pores are closed, so these are under the skin. You feel it more than you see. These are whiteheads. This patient has got combination of open comedones and red spots. This patient has got mainly red spots and some comedones again. This patient has got extensive acne, so you can see large, big spots, which we call nodule, and when you touch, you may even see cyst. So general advice, what we give to a patient is wash your face twice a day. So you want to remove any makeup, remove any grease from your skin. If possible, not to use cosmetic. And if you have to, then you use oil-free cosmetics. And comedolytics, I'm going to talk in my next slide. So generally we manage acne, we go up the ladder. If you got mild acne, you will probably prescribe an antibiotic cream, either alone or in combination with something called retinoid, which may help to unclog your pore. It may help you with pigmentation and also scarring. And benzyl peroxide and azelaic acid are also topical lotions or gel, which will help decrease the bacteria and unclog your pores. If you've got very mild acne, you can try peels, which may be helpful. Some patients don't respond to this conventional basic treatment, then they will step up to something stronger, which can be by mouth. It can be just antibiotic to start with. If they don't respond to antibiotic, or if that acne is scarring, they may straight away go to isotretinoin. Some female patients may benefit from taking contraceptive pills if there is history of any hormonal triggers. So there are a few facts about acne. So a lot of people think I eat this and my acne gets worse. So only evidence we have is about GI index. So anything that spikes your sugar is likely to make your acne worse. So avoid very sugary food, we would say, and avoid very oily cosmetics. So foundations, if you use powder rather than liquid foundations. Just to go through the myth about acne, a lot of patients think it's because I'm not washing my face. So if I do a scrub or pick, my acne will get better. And unfortunately, your acne, if you scrub or you pick, it's going to leave you scarring. So we always advise do not touch it, let it go through its own healing cycle. So a lot of patients say, I'm stressed, it causes my acne. So we say stress is not causing your acne, but it's intensifying your acne. Now, a few things you can avoid. So if you're using too greasy ointments on your face like cocoa butter or shea, that will stimulate your acne. So avoid using that because it will block your pores. Use products which says non-comedogenic or gentle cleanser, which has got a little bit of salicylic or glycolic acid. It will help with exfoliation and open up the pores. These are a couple of websites, which is patient association website, and this will be helpful for the patient if they want to go through some of the latest treatments. So this is for psoriasis and this is for eczema. And thank you for listening.
Thank you, Namita, for sharing so much really helpful and useful information. And I'm sure we're going to get lots of questions. I already have 8 or 9 questions that have been posted for us. So we'll talk about those a little bit later in the Q&A. And everyone watching us, yes, if you do have questions, please put them in the chat on YouTube. You can also send them to our email address, owl@oshwal.org. And we will continue with today's session. So my next speaker today is Dr. Pamela Kaushal, a consultant psychiatrist from the Oxford NHS Foundation Trust. She and her colleagues serve a wide area around Oxford, South Buckinghamshire, and parts of Berkshire as well. We're really fortunate to have you with us today to share with us the information around some of the mental conditions that are associated with skin disorders. And when we were talking, Pamela, you were telling me about the number of referrals you get from GPs about this very topic. So it would be good to hear what's happening currently. Are we seeing any increase in this kind of referrals given the period of difficulty we've all come through in the last 2 years? And yes, so we're very lucky to have you, and you're ready, please start.
Very good evening to all of you. First of all, a big thank you to Prafulla for that introduction, and also to Dr. Namita Jasani for the very informative, very detailed presentation on the most common skin conditions that she explained very well. So a bit of background. I was asked to join this very good seminar today to sort of link in the sort of physical side of the skin disorders and the psychological aspects. Just to give an introduction into my background, as Prafulla mentioned, I'm a consultant psychiatrist and I'm employed by Oxford Health NHS Foundation Trust. And I've done all my training in Oxford, and I'm very privileged to be working in mental health, because at the moment, what we're seeing, not just during this pandemic, when the pandemic has definitely amplified the problems with people's mental health because of all the lockdowns and the stress that this pandemic has caused. But also, I think generally, mental health is not very well talked about. It's especially within the Asian communities. I noticed that it's a subject that has got a lot of stigma around it. So people would rather not talk about mental health. And what I came to know, I went to India for 1 year in 2018. I took a sabbatical from my career, and I did voluntary work in a charitable hospital, 3-4 hours away from Delhi. And in that hospital, I noticed that many people would come to see me with conditions, but they would not call their condition a mental health problem. So they wouldn't say they have anxiety or depression. They would call it abdominal pain or headache. So they would give a physical name to the symptom that they were coming to me with. So that was very interesting for me to know that people in the Asian subcontinent will not converse openly about their mental health because of all the issues surrounding it. And people are expected just to get on with life and, find a solution. And that's not the case. So what we do now understand is that the body and the mind connect is very strong. The current understanding in psychiatry is that the brain and the mind are separate. Whereas in the Asian school of thought, as I'm sure many of you who are from the Asian community realize, that in our culture and our traditions, we believe that the body and mind, the mind and the brain are in fact the same. So the brain, the human brain, is just an instrument for the mind to project. So as we all know that we sleep at night, and we, our brain is still functioning. All the functions of the brain are happening, but the awareness is not there in sleep. So the fact the body is still functioning as well. So what we are sort of progressing towards in mental health now is getting a deeper understanding of the mind. And there's been a lot of work to look at the body-mind connect. And as we've heard today about these skin conditions of eczema, psoriasis, and acne, these 3 conditions which Dr. Jasani talked about in a lot of detail. She also mentioned the word stress as being a potential trigger for psoriasis and even eczema. So I wanted to spend today's session just thinking about this idea of stress and how stress impacts on the skin. Not just the skin, you see, the stress will impact every organ in your body, every single organ. But because today's topic is on skin, that will be the focus of my talk. I'm not giving any PowerPoint presentation because I want us to sort of concentrate on the facts that I'm saying, so that otherwise the attention would go on slides and things. And I think my idea is to sort of convey what I encounter in my daily practice of seeing patients. So I manage a team called the crisis team. I get the most unwell patients coming to me. I serve about 35 GP surgeries in South Buckinghamshire, and I get over 300 referrals a month come to me. And some of them do have the mention of people having an issue with their skin in some shape or form. So I will talk about that. And the other part that I'm going to talk about is self-image with skin conditions. We heard from Anthony earlier. Anthony showed us his hands. And, Anthony is doing a very, specialist job. He has a very important role, lots of responsibility in his job. And when we're meeting with people, our image, our personal appearance has a huge role to play in our human interactions, and skin being a very important part of our appearance, that has psychological consequences on people's self-esteem, their confidence. So if you're having psoriasis, if you're having eczema, if you're having acne, how you perceive yourself, what your confidence is in interacting with others. Do you shy away and stay away from the public? You'd rather not go to social events and be part of a community because you feel people will look at you in a strange way, or pass judgments about you, or feel that you have some sort of contagious condition. So there's various behavioral consequences of having skin conditions that lead to people then developing low mood, low self-esteem, and consequently the behavior of self-isolation. And self-isolation then worsens depression and feelings of unworthiness. So that is also a very important part, the self-image that goes together with skin. And then I also want to spend a few minutes talking about a condition known as OCD, obsessive compulsive disorder. And it's a condition, it's an anxiety disorder, which leads to people doing rituals, repetitive behaviors. And one of the most common parts of OCD is fear of contamination, fear of being unclean. And what we notice in our clinical practice in psychiatry is that we get patients who are washing their hands repetitively because it's a way of dealing with the inner restlessness, the inner anxiety. So they are forced by their mind to engage in an activity which will make them repeatedly wash their hands, and the mind tells them to do it again and again and again, and that leads to several hours of washing, and that can cause skin problems. And I've seen people's hands with OCD who engage in this prolonged washing. They get cracks on their skin, even to the state of bleeding, and those patients can even wash their clothes excessively as well with lots of detergents, and then that can have a consequence on the skin. So OCD is a very, very common condition, not just in the UK, but around the world, one of the most commonest anxiety disorders. So that's an introduction. I've tried to summarize. It's not possible to talk about this whole topic in 20 minutes. I'm very happy to, have a follow-up session if people wish to explore that with me. I don't do private practice. I'm just employed by the NHS, but I feel that especially in the Asian community, there's a lack of a proper understanding of mental health conditions, and therefore people like me who are employed by the NHS, it's our duty and responsibility to ensure that where there is that gap in understanding, to bridge that gap. And nowadays, I know that GPs are very stretched because of COVID. They perhaps aren't seeing enough patients face to face. Primary care is going through a lot of stress at the moment. So, GPs don't have enough time to spend with patients in their consultations discussing the mental health aspects of, these disorders, whether it's skin or other, psychosomatic problems. So I've just used that word psychosomatic, and I'm just going to spend a few minutes. What is this word psychosomatic? So somatic refers to the human body, and psycho refers to the mind. So any illness that connects the body and mind is called psychosomatic. So what we know is that stress, we all talk about stress. Now, what stress does to the immune system is very interesting. So what stress does is it activates two pathways in the neuronal pathways in the body. And one of the pathways starts from the pituitary gland, the master gland in the brain, and then goes and activates our adrenal glands. Now, these two glands are sitting on top of our kidneys, and they release stress hormones. And many of you may have heard of adrenaline and cortisol. So, for example, if, let's say, a big tiger, excuse me, enters the room, what would happen? Excuse me. So my stress hormones will get activated. Sorry, I'm just going to take a pause, just 1 second. Apologies for that. I've had a slight cold and had a bit of a tickle in my throat. So just stopped to take some water. So going back to what the example I was giving was, let's say a tiger enters the room. What would happen to us? Our body would then go into a hyper alert situation, and the eyes, the pupils dilate, the muscles in the body get tense. The stress hormones cause all the blood to go to our muscles, and we start to sweat. And the stress hormones cause our blood pressure to rise, our heart rate goes up, and all of that cycle starts. And it's a vicious cycle, excuse me, that causes a lot of pressure on the body. And the response is a fight or flight response. So the body is getting ready to run, to get away from the stressful stimulus. And that is what stress does. It activates the neuronal pathways to cause cortisol, adrenaline to get pumping in around your body. And then there is this vicious rise of inflammatory markers in the body. And those inflammatory markers cause inflammation to take place. And that is where Dr. Jasani was telling us that psoriasis can be triggered by stress. So any inflammation in the body can be a result of stress. Stress starts off that neuronal pathway which is triggered from the center of the brain and then kicks off to sends a signal to your adrenal glands, and then your adrenaline, your noradrenaline, these stress hormones start to get activated, and then they rise in the bloodstream. So what we have to think about is, yes, we have to keep the stress levels low, but there are certain individuals who are more at risk of stress because of life circumstances, because of, they have a family history of mental health conditions, various reasons that are beyond people's control. And so managing the stress, what we in mental health do, we take a two-pronged approach. Medication can be helpful, such as antidepressants. They are used for anxiety, for depression. And apart from that, I know my GP colleagues give medications such as beta blockers. So beta blockers are medications like propranolol. Some of you may be hearing of propranolol or used to this medication. And what propranolol does, it acts to dampen down the stress response by slowing the heart rate down, bringing the blood pressure down. So some children, before their exams, they get this exam anxiety or stress or performance anxiety if you have to perform on a stage or something. So GPs would give this beta blocker. So this is a very low-key treatment to deal with stress, beta blockers. But when people are referred to specialists like me, then we go for the antidepressant therapies, which are used for treating anxiety and depression. With that tablets are not the only way. Talking therapy is very, very important. So psychological therapies such as CBT, some of you may have heard of CBT. CBT stands for cognitive behavioral therapy. Now, because we know of the body-mind connect, which I explained earlier, any emotion, whether it be fear, whether it be anxiety, whether it be happiness, sadness, feeling like crying, anger, jealousy, any emotion experienced by the human body is preceded by a thought. no one can feel any human emotion without a preceding thought. So that is the theory behind CBT, is that there is a thought, and if we examine the thought, then we can target the emotion, and then we can act on the maladaptive behavior. So the maladaptive behavior could be, I have eczema, I have psoriasis, I have acne, I'm not going to meet anyone. But before that, a thought has occurred that I don't look good. People don't like the way I look. People think I have some sort of terrible condition, it's contagious, and people keep away from me. Maybe people have had, patients may have had that experience at work or in a social situation where they felt that people are judging them. And that thought then leads to that emotion of feeling anxious if I go amongst people. And then the consequent behavior of avoidance comes in. So that's the CBT cycle. The body, mind connect. So our thoughts lead to an emotion, and an emotion leads to behavior. That triad, that triangle, is what my psychologists, colleagues who I work with who give the CBT target, and they help people realize that your emotions are separate from your thoughts, and we are separate from our thoughts as well. So I am not my thoughts. I have thoughts. My brain's job is to think. My brain's job is to churn out thoughts, a bit like my heart. Its job is to beat. I don't control my heartbeat. My heart beats during the sleep as well, but it's my brain's job to think. And it will think all kinds of thoughts. We have thousands and thousands of thoughts. Many we don't even remember what we thought of earlier this morning or then, 10 minutes ago. So thoughts keep changing. So the idea of the psychological therapy would be to look at the thoughts and to examine them carefully and look at the origin of the thoughts. And as we start to become observers of our thoughts, that then allows us to feel a sense of detachment from the thoughts, a separateness from the thoughts. And then one can then deal with the thoughts and not be so disturbed by them, because they then become weaker. The thoughts then lose their power on one person, and they no longer will have the corresponding anxiety, emotion that comes from the thought. So that is what CBT is about. And CBT is available now through the NHS. People can now self-refer for CBT. You don't even need nowadays a GP referral for CBT, but it is the most evidence-based and the best form of therapy. And what we know, our evidence tells us that it is a combination of talking therapies and medication, which gives the best outcome for anxiety, for depression. And psychosomatic illnesses, what we do know is they are more harder to treat. Any condition that affects the body and consequently makes people anxious, health anxieties are very difficult to treat. But if you're somebody who's listening to this talk today and has struggled with worrying about your physical health to an extent that it becomes to a point of an obsession, and you can't get rid of that requires specialist help from a psychiatrist, from a psychologist, and ask your GP to refer you. But stress, this is a very big topic, and it's not possible to cover it all in 20 minutes. But I also mentioned OCD, and OCD is an anxiety disorder which can lead to skin conditions. So it's the other way around. It's not the skin condition leading to the mental health condition. It's the other way around. The mental health condition then leads to a skin condition. And there are many other conditions in psychiatry, that we deal with. So people over the age of 65 start to present more with health anxieties, and they may start to develop fears around that something's happening to their skin. I've seen a lot of older age eczema triggered by stress and worries, that various worries about death and dying, that triggers off a whole range of physical symptoms. And the physical symptoms that I mentioned, the heart rate going up and the mouth getting dry, becoming sweaty, shaky, dizzy, and then these other conditions, that the skin is one of the best examples of psychosomatic illness, because it's been mapped so closely. So if this is a talk that you feel that you've benefited from, then I'd be very happy to provide an ongoing session on and dealing with the idea, the concept of stress and inflammation and anxiety as a consequence. So I think I've done my time for this talk, and looking forward to taking some of your questions. Thank you.
Thank you very much, Pamela. That was really actually thought-provoking in terms of understanding the connection between what our mind says and what our bodies feel. And particularly the conditions that you talked about where skin can be affected by stress. So, આપણી પાસે એટલા બધા questions છે અત્યારે, I think we've got about 18, 19 questions to take. Our panel will do the best to answer them. There are some that may be similar, but there are many that are not similar, and they talk about a number of different areas of skin disorders. So I want to say thank you to our panel, and let's do the Q&A now, which Tusharba and I will facilitate. And hopefully we'll get through as many of the questions as we've got here today.
So thank you, Dr. Namita and Dr. Pamela. Yeah, excellent presentation. And in case you're not aware, I'm a past practicing pharmacist, so I'm quite aware of what you're talking about. It's a pity that you were not my lecturers, because what you taught me in 1 hour, it took me 3 years to learn through my existing lectures. But joking aside, no, excellent presentation, and what you actually said explained everything so simply. Yeah, that both go hand in hand about the treatments and obviously the mind, how it affects your body. Yeah, and today we have a case study, Anthony Fernandez, who's actually explained to us that he's affected, his psoriasis is actually affected by stress. And his answer is, if he does retire or went to Bournemouth or Canada or somewhere else away from stress, his psoriasis will go away. Now, obviously, it's not practical for many of us to do that in a certain stage of our life. So he's trying to cope as best as possible. So we're going to go through questions for all of you through this session to ask you your opinion on this. So do you want to take the first one, Profulaben?
No, go on. You take the first one, and then I'll go with the second. So we're going to rotate them between us.
Okay, that's a big word for me when I've not heard of this. Can you cover cutaneous vasculitis and leukocytoclastic vasculitis? Yeah, and are there any skin conditions that people get after having COVID injections? Either one of you who's knowledgeable on this.
Should I take that, Pamela? Yeah. Leukocytoclastic vasculitis essentially means you got inflammation of the blood vessels in the skin, and leukocytes are the white cells, so the white cells are causing the inflammation. That's a completely different skin condition from what we have spoken today, eczema, psoriasis, or acne. And it itself is a very broad topic. What can cause it, how you treat it, how you investigate it. And conditions which can happen post-COVID, yes, we know COVID is presenting as on the skin as well. So we would have patients who have no other symptoms, but would present with COVID toes, where the toes will appear pink, purple, and bluish, and they last for a few weeks. And if you do testing, they may come COVID positive. Or COVID may even present with different kind of rash in the body along with fever. So they may have a little spotty rash or little blisters, or they may even have hives on the body as a part of COVID. So COVID, we are still learning a lot about it, and it is having a varied presentation on the skin.
Thank you. Profulaben.
Great, thank you. So I have a question from one of our viewers. Says, I have a small patch of skin rash on my face, which is itchy at times. My GP tells me it's eczema and has prescribed moisturizing cream, a steroid cream, to use it often, as you said, Namita, in your presentation. They're saying they've tried, but it's not improving, and in fact, they feel that's getting bigger. So do you have any advice for them?
So first and foremost, obviously, patient needs to be reviewed. Is the diagnosis of eczema correct? If it's correct, why has she not responded to the steroid cream? Is the steroid cream enough? Do we need to go up on a slightly stronger strength steroid? She's already using strong strength steroid. Is she using it correctly, the right amount? Is she under-treating herself? A lot of patients have steroid phobia, even though we prescribe, they under-treat and they just do not get better because of under-treatment. If she's using it correctly, then maybe looking into different treatment like immunomodulators, which are steroid sparing, if that works for her. So I think because her patch is localized, it's probably going to be topical treatment for her.
And do you find often that people do end up going back to the GP, time and again for these kinds of reviews before they come to you, perhaps at a hospital and as a referral?
So being in hospital, you're quite specialized. So anything small like that will not make it through our doors. So they will have tried 2-3 treatments or the condition has worsened before they present to us.
Thank you.
Okay. Yes. Okay. Dr. Pamela, one question that was you raised. You talked about prescribing propranolol for stress, and that could relate to Anthony Fernandez. Now, as a past practicing pharmacist, I remember going back 30, 40 years ago that propranolol was being prescribed, but then since then, obviously, it's been phased out over the years, new medications come in. Is it something that you still prescribe or recommend to patients out there, or some modern medicine now?
So that's a really good question, Tushar. Basically, the current practice is for GPs to prescribe propranolol at the primary care level where there isn't a clinical depression or features of anxiety to the point where people are disabled that they cannot function. So if your day-to-day function is okay, you can get to work and look after yourself, and you're not disabled by anxiety and depression to that level, then GPs will start off with a beta blocker. It's very common. I get many referrals with patients who started off and perhaps still are taking a beta blocker. But when it gets to the stage where the patient doesn't respond, the anxiety no longer responds, because in fact, the beta blocker is not treating the anxiety. It is only dampening down the effects of the stress hormones, the cortisol and the adrenaline, and that's all. By reducing the heart rate and bringing down the blood pressure, so people don't feel the physical effects. But it's not actually treating the anxiety, so to speak. So, I mean, if people aren't troubled by the anxiety, it's kind of your first tier primary care medication. And I see GPs giving it to, people who have performance, have got to give a big presentation somewhere, or they have, a sort of milder stress level, which, a beta blocker can perhaps hold. So, yeah.
Okay, thank you. So, Professor Ben.
Thank you. The next question is that, is itching skin all over the body a sign of cancer? And the viewer goes on to explain that her mom and a friend were both had intense itching all over their body, severe and inflammatory skin condition in the face and the arms, and constant itching, and both were actually diagnosed with breast cancer. So this is one of those questions, I guess, that comes up time and again. Actually, I've heard this before. And they're going on to ask, should we ask the GP for a blood test in this situation? Don't know if you want to take that, Namita.
Yeah. So itchy skin, which we call pruritus, again, it's a broad topic. So you start with the history. Why is the patient's skin itchy? Is it happening at a certain time of the day? What do they use for washing their skin? You examine their skin. Most common cause of itchy skin without any rash is dryness of the skin. As we age, the skin gets dry, or because it's winter, skin is dry. You're not using the moisturizer. For certain, you get the history. If there's nothing in the history which suggests weight loss, loss of appetite or any change in bowel habits which pointing towards a cancer, then I would not start digging into it. But obviously, if somebody has a very strong family history, you want to do some investigations. So we don't do straight away investigation. We do look into the history. There's nothing in the history. And itchiness is intense, not responding to moisturizer, not responding to antihistamines, then we would go into doing blood test. And yes, it can be a presentation. So it's not something I would completely dismiss. But it's not something I'm going to encourage every patient who comes into the door saying, oh, you can have malignancy. No, it can't be. It's uncommon presentation. But if you rule out everything else, you can't find a cause, then do think of it.
Thank you. So we have a question here from one of the viewers that he was prescribed steroid ointments, yeah, and he's not happy using that as long-term. Now, I think Dr. Namita did prescribe the alternatives, what is out there apart from all the steroids, what the other alternatives are, which is the emollients, the bath oils, moisturizers, etc. So, Anthony, a question for you: what were you prescribed, and what stages, what medication were you put under?
I've tried all sorts of creams on my hands from the doctors, but to be honest, Tuksha, as you know, the one that really kind of helped immensely is the one that you wouldn't give me the name of, that you actually gave me. Maybe you can actually tell me now what it is, because it does actually work, especially like at the beginning of the month and stuff like that, where I use it at night. It's very greasy, and I use white cotton gloves and sleep with it on. And by the morning, and I wash it off in the morning, and it seems to kind of ease it during the day. But obviously, towards the end of the month, when I get really stressed, it doesn't help immensely. But it is a useful sort of cream to actually have. It's a lot better than some of the other creams that was prescribed, from the doctors. But I don't know what it was called, so I'll be coming back to you to try and get some more.
Save it as your secret Santa gift then.
Okay, so Dr. Namita actually touched on his emollients, yeah? She talked about having water when you use the cream and we use the ointments. Ointments are greasy. Now, what, like I said, as a pharmacist running a retail pharmacy for 25 odd years, yeah? We used to see a lot of patients coming through our doors regularly, and especially the elderly. Over 75–80% of the elderly were always on moisturizers or bath oils or emollients, just because as you get older, your skin dries out.
Yeah.
So literally, I would call it 75–80% are on emollients or dry skin. And we used to dispense this regularly for our patients regularly. But one of the things that I'd always been passionate about is, I call it in Gujarati, it's called Desi Dawa. Yeah, you have all the modern medicines available out there. Yeah. And I never got around to doing it when I was a pharmacist, but when I retired from pharmacy itself, I always had a passion that I wanted to develop something myself. Yeah, and you probably heard of this, Fuller's Earth. I don't know if you're aware of that. Yeah, Fuller's Earth is a lot of ladies, a lot of people use it as facial moisturizer scrub. Yeah, they make a paste out of it and put it on their faces, etc., on their skin to help moisturize it, nourish it as well. So I had a ointment specially made, Fuller's Earth cream. It contains kaolin and zinc oxide. Zinc oxide itself is a natural astringent, anti-irritant, etc. Now, this ointment is actually much more greasier than what you would buy in a pharmacy. And like Anthony said, I just gave it, I saw the psoriasis and I said, what have you tried? He said, I've gone through all of this. So I gave him a pot of this cream that I'd made up, yeah. And I actually said within a couple of weeks, it had helped. And it's something that you touched on, Dr. Namita, which is your skin breaks up. So what this cream is doing is actually putting a barrier on your skin. So it is, by putting that barrier, it's like a nappy rash cream. It puts a barrier on there. So it allows the moisture to be retained within the skin, and it allows to nourish the skin as well at the same time. Yes, you use it at nighttime and you put gloves on it, etc., or cover it up so because it is quite greasy and oily. Yeah, but over a period of time, it does tend to. I've given it to several people, and it has helped them. Yeah. So, Anthony, I'm glad that you were my first patient that I tried it on.
And excuse me, as a guinea pig.
I've given it to other people with dry skin, and actually they say, yes, it's very greasy, but it's doing wonders. I call it desi dava, as you call it. Yeah. It used to be it's a 150-year-old formula out there. Yeah. And it used to work in the past, but over the time, obviously, with modernization and new products in the pipeline, all things get forgotten. Yeah.
Yeah, I think in olden days, herbs were the medicine because we didn't have synthetic medication. So I think it's one of those things which have natural ingredients, they still work.
Yes.
We don't use in modern medicine. We just believe in evidence base, unfortunately.
Yeah. Okay, so Prafula,
get ready for lots of people coming through to you asking for that little pot. And I'm sure Anthony is looking for his next pot as well. I will come back to you, Auntie, because I've got a question for you in a couple of minutes. But my first one now is somebody's asking, they've got psoriasis, a recent kind of flare-up of psoriasis, 4 months. And it started on the scalp, a bit like one of those pictures you showed us, I think, in your presentation.
Yeah.
And has been prescribed steroid ointment and gel for the scalp, and gets flare-ups. Not happy using the steroids. And I think you touched on this as well when you were talking about it. They're asking, can it be diet or allergy related, or could they be the triggers? So, is there something they're eating that's causing this? And are there any alternatives?
So psoriasis and diet, there is not enough evidence to say that psoriasis is triggered by diet. Only thing we know diet-wise, alcohol would be a trigger if there is any history of alcohol ingestion that's triggering a psoriasis. As regard to the scalp skin is very thick, and I would not be worried to use steroid, because if you use steroid regularly for a few weeks, you're going to break that psoriasis and your skin will get a chance to heal. And after that is how you maintain it, by using steroid on and off, or different lotions or shampoos to keep the scale off. Obviously, some patients do go on drugs by mouth if it's bothering them enough, it's affecting their quality of life. So obviously, we will go through the step, what have you tried? Why have you not tried this? Why this hasn't worked for you? But there's not enough evidence to say about diet and psoriasis.
So there's a few duplication of questions, and I won't go through that. Obviously, it's talking about eczema on different parts of the body. Now, one of the questions is, somebody's getting eczema on the fingers, etc. Why does it pick on the fingers or the hands or the head or whatever? Where does it first originate from? Is it the weakest point or the easiest point that the body is able to react to?
That's $1 million question, is why it happens in this part of the body. So inflammation can happen in any part of the body. So you can get eczema in any part of your body. But we see some trend, as I showed in one of my slides, that in infant it tends to localize anywhere. But as you go in childhood, it localizes to certain areas of the body which are more predisposed because the skin is of different texture on this area. And as we grow into adult, it tends to localize more to our hand and feet. Why it happens, we don't know.
Okay. So, Dr. Pamela, is eczema or psoriasis, dermatitis hereditary? You're on mute.
Yeah. So, sorry, this question is, so you're asking me if these skin conditions are hereditary?
Yes. Or is it all
I think that's more for the dermatologist to answer, I was going to say.
I'll take that. So eczema has a strong genetic predisposition because we know filaggrin mutation, which is the reason why you can get change in the skin barrier, and there is a linkage, genetic linkage. And psoriasis also we know has a genetic linkage. So yes, to both.
Thank you. Prof. Labin.
So I think my question, the next one possibly is for you, Pamela.
Okay.
The viewer is asking, can you remove discoloration or pigmentation from eczema? And this is to do with obviously how we look and how other people look at us, from this discoloration. I think I know the answer to this, but what's your view?
Well, I think, again, that's a question for...
Yeah, I'll take that question.
That's,
I will come to you though, because I want to kind of explore this idea that people think that you can cover up your, these kind of patches or anything, because that's your outward looking skin and other people's kind of view of that and how you are feeling yourself. So I'm going to come back to you on that, but maybe, Namita, can it be?
So depends what kind of color it is. Have we gained too much of color, which is, have we got hyperpigmentation? If it's hyperpigmentation, it will fade naturally. The body will lose the color. Some patients who do not have eczema or they have some other skin condition, they are left with pigmentation. We can give them creams to take the pigmentation down. But in eczema patients, those creams will be very irritant because they can have bleaching agent in it. So we would say to eczema patient, no, you just have to wait for your body to heal it naturally. And if you're lost color, it's very hard to gain the color back through any creams. Your body will regain it over a period of time.
Okay. So what do we think? How do we think that people who perhaps are going through these very stressful conditions and then find these things happening? And actually, Anthony, you referred to it when you were showing us your hands, and you said when people shake your hand, sometimes, you get that feeling of that hesitancy. Has it ever made you want to cover that up?
Always, especially when I go into meetings and stuff like that. Normally at the end of the meeting, when you have to shake someone's hand, they kind of, you're kind of reluctant to actually put your hand forward. Some people just accept it. Some people will kind of, you can tell that they're kind of backing off. But you just get used to it. And I only give my hand if someone offers the hand sort of thing. It's just, you get used to it.
So you've sort of learned to manage it.
Exactly. Even like when I'm sitting down here, I'm kind of covering my hands so that people don't kind of stare at my psoriasis. But it's, I don't know, I've been with it now for a long time, so I just get used to hiding it, and I'm always aware of it. But it's a way of life, I suppose. I just have to cope with it.
Yeah, well done. Okay, Kaushal bhai.
Okay, so is eczema also hormone related? Ladies had bad eczema, including like psoriasis, but it disappeared after she had a hysterectomy.
So there is a variant which we call progesterone dermatitis, where patient would get eczema eruption on the skin during the second half of the cycle when there is progesterone levels are high. So yes, it can be, it's not common, but you can see progesterone dermatitis.
Thank you. Dr. Prafula.
So I've got a question, says, the viewer says, how do you treat keloid scars? And that's spelled with a K.
Yeah. So keloid scar is when your body is overhealing, and some people are more predisposed. So if it's a very fresh keloid, and it's a soft, you can put steroid tape on it. If they don't respond to steroid tape, then you could inject steroid into the keloid.
Kaushal bhai, you've got an order for your cream.
Yes. There's a lady who's asking, I was hoping you would mention melasma. Melasma, in case you're not aware, is skin discoloration. So, Dr. Namita.
So melasma is a very broad topic to talk about. So you get discoloration on the face, essentially on the cheek and the forehead, and it is hard to treat condition. There are treatments available like chemical peels, bleaching agent, which will help. Again, looking into history, are there any drugs which are causing like contraceptive pill with the patient on? And the sun is the main trigger, so using sunscreen regularly is the key. And there are lasers available which can target melasma.
Thank you. Prafula.
So my next one is, what is the cause of urticaria? And he says he suffers from it in Gujarati. I think it's called Shiraz.
Urticaria, again, it's a broad topic. What is the cause? There are n number of causes. So from common things, any infection you get it, that will trigger your immune system. And while it triggers the immune system, it goes on a wrong chemical pathway and stimulates the urticaria and release of histamine. Your infection will go away, but urticaria can stay for months. So most common is infection. Certain drugs you react to. So you take some antibiotic and your body reacts to that. You'll present with urticaria or hives. You'll stop the antibiotic, but urticaria may stay with you for a few months. In kids, if you see it as an acute presentation, you want to think it's related to food. Is there any trigger in the food? Then you look into the history of the food. So there are multiple causes for urticaria. So you need to look into the history. And many times you do not find a cause, and we call it idiopathic urticaria.
Okay, a question which came by email. And this is something that obviously we noticed in retail pharmacy as well. Now, as you get older, we find that people don't tend to drink as much water as they probably did when they were younger. Now, especially in older age, you need to drink a lot more water to flush all the bad aspects of the body, the waste out. But what the older people tend to worry is that they end up going to the bathroom that often. But does drinking a lot more water in an old age actually help to nourish the skin, keep it moisturized, or is it just a fallacy?
So hydration is important. You do need to hydrate it because dehydration will make your skin look wrinkly. So you need enough amount of water. You don't have to overdrink, underdrink, but moisture directly into the skin is going to come from the moisturizer. But just keep your whole body in circulation hydrated, you do need to drink water.
Thank you.
How much would you recommend to drink?
They say 6 to 8 glasses a day.
Yeah, I normally drink about 1.5 liters
Good.
a day.
If you maintain that in winter, in summer everybody will, but it's hard to maintain. If you ask me, I've not drank more than 2 glasses in the whole day. Even though we advise, we don't follow it. It's just our lifestyle, I think. So our lifestyle is just so busy.
I've got a question, and then I'm going to come to Pamela. You were talking about OCD earlier. So actually, I'll ask that first, and then we'll go to the question. You said that some people, that is a condition that people wash their hands, and keep doing it. And then that affects their skin. Have you seen like an increase in that happening in the last kind of 18 months?
Definite. So the incidence of OCD has gone up because it is an anxiety disorder. So we've seen more people sort of developing that coping style of the distress because they can't, meet up with family and friends when we have the extreme lockdowns. And, OCD related behaviors, that's the way of the mind dealing with the anxiety. People who have a, propensity to OCD, they naturally are, either have a, family history of OCD or, an anxious personality. They're more at risk of developing OCD, but we've seen a rise because of this current pandemic that have had, more complications of, excessive hand washing is the most common fear of contamination. And that's where I've seen some hands which have, they're to such a level of, to the point of bleeding. That's how, raw they become, as Namita was explaining, the soap, excessive soap, it cracks the skin. And that's what I've seen that in, in my clinics. But, those kind of cases then require, it's a combination of psychotropic medication to settle the OCD and the psychological therapy. So it's a two-pronged approach. We do both. But yes, there has been an increase, yeah.
Thank you. Bye.
Okay, can you explain how patch test determines the skin problems?
Patch testing, is it? So patch testing is done to find out any contact allergy. So anything your skin comes in contact with, are you allergic to that? It's quite a tedious test. It's done over a period of 3 days. So on first day, say if you pick up a Monday, you come to the clinic, multiple patches are put on your back. Those patches have a little ingredient and which has got chemicals in it, which could be from hair dye to latex glow to nickel. So it's fragrance, various standard series we do. And patches are stuck on your back with a tape. Between Monday and Friday, you can't shower, you can't make your back wet. You go on a Wednesday in the clinic, the patches are removed from your back. There is reading is marked, which is if there is any inflammation of the skin where the patches are, which patch is showing inflammation. Is it a nickel patch or is it a latex patch? And then you go on a Friday, do a final reading, and what comes positive that you're allergic to.
Thank you, Professor Ben.
Great. So, Tushar, I think I'm making this my last question. Have you got any more? I haven't seen any more. I'm seeing this
A lot of them
one.
are duplicates. A lot of them are duplicates.
Yeah. So this is our final question. Thank you, everyone who has submitted questions, some really, really good questions. And we've had some fantastic information from Namita, Pamela, and Anthony shared his lovely experience with us as well. What I was going to say is, your slides are obviously on the YouTube channel now, Namita, and I may get more questions, in which case I'll come back to you maybe by email if that's okay. And similarly, Pamela, if anyone reaches out to me about specifically the 4 things that you talked about in your presentation, then I'll contact you separately as well. So this question says, thank you for a very important and informative talk tonight to educate us on the benefits of understanding skin conditions. So question is Dipro-based ointment good for the skin rash on body parts due to stress? Also, this ointment is not now available in pharmacy. Maybe it's discontinued. If that is the case, what can we use instead?
Dipro-based falls in the middle. It's neither too greasy, it's neither too light. It is a good moisturizer to use. But if it's not available because of manufacturing issue, I think there are a lot of replacement, double base is there, zero base is there, kiwi base, there are a lot of moisturizer in the market. I think you just have to go and see the doctor to get substitute for that.
Okay. And lots of people use E45, right? So is that like a combination of those things? Because it's much lighter, isn't it?
E45 is on the lighter range, especially E45 lotion, because it's lotion, so it doesn't have much greasy content in it. So E45 cream is slightly on the greasier side, but it's something which I think has got a very popular name, and every patient you see after a certain age group, oh, I'm using E45. I think it's just a brand name. But there are a lot of similar moisturizer available in the market.
So
great.
You mentioned, actually, Prof. Laben, you raised an important question. It used to be there, but not as much now. A lot of ointments, etc., contain lanolin. Now, lanolin itself can sometimes, although it's a good moisturizer, can also sometimes irritate the skin.
That's right.
Yeah. So what are your thoughts on that?
We do get patients who actually develop lanolin allergy, and that's when they go through patch testing, and if they come positive, then we have to find moisturizer which do not have lanolin in it.
Thank
you.
The
patient comes to you and says, I use N number of moisturizers, making my skin worse. Just think, actually, patient may be right. There's something in the ingredient which is common in a lot of moisturizer that the patient is reacting to.
Yeah, and I think બીજી એક વાત હું કહીશ, જો આપણા કોઈ elderly લોકો આ creams વાપરતા હોય ને, so they're very greasy. So if you're in the shower, it makes the shower floor very slippery. So anytime બહુ ધ્યાન રાખજો, because then that can also cause additional problems. પડવાની બીક રહે, slip thawani big rate, and then for elderly people that is also another cause of obviously then other different problems. So using those things as well, I think just be very careful as well. Okay, I think we have
before we close, just obviously a lot of questions have gone to Dr. Namita. So Dr. Pamela, one final question from you. You've heard Anthony's life story, and come last week of each month, he gets stressed out. What would your advice be to him to help him, as he's a case study today, to help him going forward? Yeah.
Well, I think the fact that he's so openly come and shared his story, Anthony, that speaks volumes about you. And I think that you have an insight. You shared such good insights into the way you cope. I mean, getting away from it all. I mean, that's one way. Knowing when to stop I think that's a very important quality. Many people in today's day and age, as Namita just said earlier, she's been through the whole day with 2 glasses, hardly 2 glasses of water. So it's about knowing when we have to look, we have to put ourselves first, and, the family, the job, everything else, the world, will continue. The world won't stop if, we're not doing our, roles. So it's being kind to yourself, putting yourself first. And that's important. Loving oneself, self-compassion. That's what we are currently in the NHS trying to promote more mindfulness. That's self-compassion. You first. And if we can't look after ourselves, how will we look after other people? I mean, as doctors, Namita and I, if we are not well, how will we serve our patients? So I think, if Anthony, you always put yourself first, and listen to your body. You need to listen to your body, because if you ignore the signals the body is giving, then that's where the problem lies, and you just keep going, thinking I have to keep marching on. So that would be my advice.
I understand. Yeah, I'll try and take some of that on board.
I know it's not easy.
Tell me about it.
And I think I'm going to just add, Tushar, we've had lots of speakers come on these webinars, and they talk about the importance of fresh air, yoga, some sort of, system to de-stress. So anything that works for you, to de-stress, I think, I would definitely say let's do that as well. And fresh air in the winter is very important, because the heating does affect our skin. I think you referred to that earlier in your presentation, Namita. And so I would say, yes, yoga, anything that de-stresses you. Go out for a walk, go out for a run, whatever works, really, because fresh air is good for the skin, definitely.
I've tried to get Tuksha to join me in the gym, but he's never said yes to it.
Forget it. No. So we have come to the end of today's session. I want to say a big, big, big thank you to all our speakers today. Namita, thank you so much for the time you've given this. Pamela, same. I know you are incredibly busy, because you're running not just your clinics, around those 4 counties that we talked about, but also this amazing charity that you're involved with in India, and the amount of work you do for that. So well done for that. And thank you so much for joining us and sharing, what you did today. I think it will be something for a lot of people to think about. Anthony, as Pamela said, brave, very brave, and good that you did it, because I think it will inspire many more people to talk about it in the very easy way that you talked about it today. Thank you, Tushar once again.
Thank you to our speakers and Anthony.
And introducing Anthony to us. I know you talk to him over the fence every day, but it's great to have him here today. Our topic, in the next 2 topics in the webinars, we're going to talk about nutrition, and particularly the importance of nutrition in the South Asian diet, and how we can actually adapt a balanced nutrition in our diets. And then we come back in the new year, and we're going to talk about migraines, and the kind of condition of migraines. For some people, it can last for days and days. I know somebody who, when they get migraine, it lasts for a whole week, and she has to be in a dark room to deal with it. So we'll be talking about migraines, and our session on nutrition will be the last one for 2021. It'll be our session number 14. So make a note, in 2 weeks' time, we'll be back here to talk about nutrition. Thank you, everyone, for joining us. And keep joining, because I think we are learning so much from these sessions. And, thank all our professionals for the fantastic support that we've received. If you haven't seen some of the webinars, then do go and look at the Oshwal YouTube channel. They're all recorded there from March 2021 till now. So thank you, everyone, very, very much.
Thank you.
Thank you.